Hello everyone. I wanted to take some time today to talk to you about what I believe is a very interesting and important topic in the area of COVID-19 research. Most likely, you may not have heard about this research as it is extremely new, so I thought it was very important to help gain some awareness in this area. A few months ago, I had a medical hypothesis based on my own previous research. I was thrilled to see a published medical hypothesis on this exact topic. It gave me hope that we would see some studies on this area in the near future. This month, the Journal of Infection contains a small published study on this particular topic. Even though it is a small study, I believe that it will help this topic gain some further awareness. As we examine the results of this study, as well as look at factors pointing to this overwhelming correlation, I believe we will realize our protocol for COVID-19 may need to change drastically. So what am I going to be talking to you about today? This presentation is going to be all about COVID-19 and CMV, otherwise known as cytomegalovirus. And it's going to specifically focus on whether or not reactivation of CMV contributes to COVID-19 disease severity. In this presentation, we are going to go over what is CMV. We are going to go over what conditions are associated with CMV, what is the possible relationship between COVID-19 and CMV, some pitfalls to avoid in therapy, as well as treatment options. So what is CMV? Well, CMV is a very common virus. Most of us carry it. They think about 70 to 90% of the adult population is actually infected with CMV. It is a latent virus that lies in the body and usually does not cause a lot of harm unless it gets activated. CMV spreads easily through an infected person's saliva or other body fluids, so it is very easy to transmit between two people. It's related to the herpes virus, which gives you cold sores. If you do have a healthy immune system that can easily control the virus, it usually does not cause problems, like I said, but it can make people who have a weakened immune system very sick. So people who have advanced HIV, CMV can cause very severe problems. One of them is an eye condition called retinitis, and this can lead to actual blindness. The virus usually hangs out in different tissues in the body. It can affect your intestines, esophagus, lungs, brain, or nerves. And they do believe that about a third of patients in the intensive care unit of hospitals reactivate CMV, which doubles their mortality rate. So that is all the more reason for us to be looking at CMV as a potential issue in these patients that are in the hospital with COVID-19. So let's look at the different types of CMV. There are three different types of cytomegalovirus infections. The first one is congenital. That's when a baby gets it passed on from its mother in the womb. The second one is primary. That's when the first time someone, if they didn't get it from their mother when they were in the womb, contracts CMV through some type of bodily fluids, through kissing or sexual contact with someone else that's infected with CMV. And like I said, typically our immune system is able to keep this virus in check, so to speak. So most of the time, nobody's even going to realize that they get infected with CMV. And if they do, it could look something like mono. And then the third type of CMV is reactivation. That is when the CMV that's been lying in your body dormant all this time comes out. And this can happen if you have a weakened immune system from something like HIV, or it could be from just having some type of bacterial or other viral infection, and it just overloads your immune system and you cannot deal with suppressing all these latent viruses, and then the CMV will start to replicate. So this is the medical hypothesis paper that I came across in my research a few months ago, because I thought to myself, I wonder if these patients with COVID-19 are actually having a reactivation of this latent CMV, and the CMV is actually what's causing the lung issues and the mortality. And maybe it's not COVID at all, but maybe the COVID is just so much on the immune system that it overwhelms it, and then CMV reactivates. And either it's CMV alone or it's CMV in a combination with COVID-19, other latent viruses in the body. But regardless, I was very happy to see this paper out because it gave me hope that they were going to be doing research on this and maybe do some studies to look at the potential check CMV infection in the hospital if they weren't doing so already. I had actually mentioned this to my daughter's doctor when she was in the hospital and she started having some issues with almost gastroparesis. And I said, well, I know that there's not a lot of research out on this yet, but I know that from what we have seen with COVID, it looks like a lot of viruses can reactivate, and maybe it's CMV or another virus reactivating and causing her intestinal system to just basically stop. The doctor I spoke with that day had no idea what I was talking about, so it worried me that this information was out there, but really just not well known in hospitals, that it might be a really big correlation. So, but reading this published paper did give me hope that this was going to come about soon. So what are the conditions that are linked to CMV involvement that we know currently through research? There have been multiple studies linking diabetes, hypertension, metabolic syndrome, atherosclerosis, asthma, multisystem inflammatory syndrome, also known as MISC, cancer, and autoimmune disease. All of these have been linked to potential CMV involvement. With diabetes and hypertension and atherosclerosis, there's a lot of data out there on those. As far as cancer goes, I recently read a study where they looked at breast cancer tumors, and there was over a 90% incidence finding of CMV in breast cancer tumors. And that is also linked to other types of cancers, ovarian, I believe prostate. There's just multiple types of cancers that are linked to CMV. And CMV is also one of the potential culprits that they think could be involved in certain types of autoimmune disease. Just like EBV, which is a virus that is linked to multiple sclerosis, they also think that CMV could be a potential trigger for multiple sclerosis, but it's also linked to multiple types of autoimmune diseases. So how could CMV cause diabetes? They're not really sure. There's still some research ongoing thinking that it could infect the pancreatic cells. So it actually has been implicated in not only type 2 diabetes, but also in type 1 diabetes. So there is some research out on this, and you can take a look at this particular study if you're interested. It's interesting that with COVID-19, there has been a surge in the incidences of new cases of diabetes. So that is just more of an indication to say, could CMV be involved? Because it has been linked to increased cases of diabetes, and COVID-19 is increased cases of diabetes. So another area to potentially examine. When we look at the patients who are most susceptible to severe complications from COVID-19, we know that these are the biggest risk factors, and those are high blood pressure, obesity, diabetes type 2, cardiovascular disease, male sex, and high age. And as you look at these are going to be, aside from male sex, because either males or females can be infected with CMV, all of these listed factors, the high blood pressure, obesity, type 2 diabetes, cardiovascular disease, and high age can all be linked to increased viral load of CMV. The severity of the disease and the mortality risk increases with age, but previously healthy young persons may also develop severe disease and need ICU treatment. So in the beginning of the COVID surge, we saw mostly patients who were of advanced age being the most susceptible to COVID, or people that had underlying health conditions like high blood pressure, type 2 diabetes, or heart disease being at risk. But we didn't really see it in kids. And now we are seeing more incidences of kids, and the mortality rate does seem to be somewhat higher than it was in the beginning. And it just makes you wonder if this new variant is also causing more of a surge or more of a reactivation of CMV, because CMV is something that children can carry as well. So COVID-19 and MISC, maybe you have seen this on the news, and it does seem to be, like I said, a problem more now. So with children, CMV can hang out in different tissues, and upon reactivation, CMV has been linked to MISC. And what happens basically in that condition is that it's due to the own body's immune response. So when a virus starts to replicate, the body is going to use all means of the immune system to attack this virus. And unfortunately, it can start to cause damage to the heart, lungs, kidneys, brain, wherever the virus might be during that immune attack that is needed. But in some cases, it causes a hyperinflammatory state, and that is what can result in the MISC. So here is the Journal of Infection, and this was the publication that I looked at this month. They have a new study out, and it's called Cytomegalovirus Infection in Critically Ill Patients with COVID-19. So I was extremely happy to see this study come out. So let's try to take a look at what this study looked at and what the results were. So previous studies have shown that patients hospitalized with COVID-19 have high-risk secondary infections, intensive care admission, prolonged mechanical ventilation, and severe lymphopenia, which are likely causes. CMV has infected the majority of people globally. The reactivation of CMV occurs in 30% of immunocompetent patients with acute respiratory distress syndrome and is associated with increased mortality. CMV reactivation is especially concerning in patients with COVID-19 because of acute respiratory distress syndrome being a severe complication of COVID-19. However, data on CMV infection in critically ill patients with COVID-19 is scarce. Therefore, they evaluated the frequency and clinical characteristics of CMV cases in COVID-19 patients who were who required mechanical ventilation. So they were able to retrospectively review consecutive patients with COVID-19 who required invasive mechanical ventilation for more than a week between these dates that they listed. And they made sure that the patients had had a valid PCR, a nasal swab or throat swab, and they did the screening by the items that they've listed here. The CMV disease was classified as proven, probable, or possible according to a previous study. Data was presented as median and interquartile range. Continuous variables were analyzed using these measures that they listed, and they recorded the duration of mechanical ventilation as the time of initiation to the CMV diagnosis. So let's take a look at the results that they had on this study. So they had a group of 26 patients that were placed on mechanical ventilation, and 6 of those patients developed CMV infection, and 20 of them did not develop CMV infection. So this infection developed after the patients were put on mechanical ventilation, which is a risk factor for potential CMV just in itself. The age of the patient groups is pretty comparable. 76 in the CMV group, 72 was the average age in the non-CMV group. Let's jump down and look at lymphocyte count. As I said before, lymphocyte count, direct correlation with disease severity, and you can see that in the CMV group, the range was 234 to 476, and in the non-CMV group, it was considerably higher, 412 to 723. Looking at C-reactive protein, which is a measure of like inflammation, not too much difference, although it was a kind of a large range. So 5.45 to 16 was the range in the CMV group. So there were some people that had really high CRP. And then in the non-CMV group, it was 4.26 to 10.24. And then all the patients were also put on corticosteroids. So 6 in the CMV group, 20 in the non-CMV group. The duration of mechanical ventilation in the CMV group was 31 days average, and then in the non-CMV group it was from 13 to 31. So there was a lot lower level in many of the patients in the non-CMV group. As far as bacterial and fungal infection, we've got 83.3% and 66.7% in the CMV group, and then in the non-CMV group we have 25% and 10%. So a lot less incidence of these secondary infections in the non-CMV group. And then death percentage. So the death rate was 33.3% in the CMV group and then 0% in the non-CMV group. So once again, I just want to reiterate that these were patients that developed CMV after being placed on mechanical ventilation. So the diagnosis of CMV came after they were put on mechanical ventilation. So let's talk about CMV and lymphocytes. What is a lymphocyte? So a lymphocyte is a type of white blood cell that's part of the immune system. There's 2 types of lymphocytes, B cells and T cells. B cells produce antibodies that are used to attack invading bacteria, viruses, and toxins. So lymphocytes are extremely important, and it's extremely important to have a high number of lymphocytes, especially during some type of viral infection like this. Viral, bacterial, parasitic, and fungal infections are a common cause of lymphocytopenia. Any type of serious infection may cause your lymphocyte count to fall. CMV infects epithelial cells, macrophages, and it just so happens T lymphocytes. In transplant patients, a drop in lymphocyte count is a consequence of CMV infection, and it's typically associated with fatal CMV disease. So lymphocyte count in COVID-19. So there was a study that was published recently, and the name is Analysis of Absolute Lymphocyte Count in Patients with COVID-19. And previous studies determined that a low lymphocyte count was commonly found in patients with COVID-19. So they did a retrospective chart review with about 312 patients, which is a decent number of patients. And they have listed all the cutoff values and everything here for you. If you'd like to review that, you can certainly look up this publication. But they just wanted to, look at a larger database of patients to see how well they were correlated. And in COVID-19 patients with severe pulmonary inflammation, SARS-CoV-2, results in functional exhaustion of cytotoxic lymphocytes at an early stage, which may result in disease progression. So your lymphocytes are incredibly important during an infection with COVID-19 or any viral infection for that matter, but it does seem to correlate with disease severity, very specifically with COVID-19. To look at something a little different, I wanted to examine how someone who had possibly CMV versus another patient who had CMV, would there be anything going on in their body nutritionally wise that would give them an edge to survive over this other patient? Because like I said, most of us do carry CMV, so that cannot be the determining factor. What other factors in the body could be the deciding factor as far as progression of COVID-19 or progression of CMV for that matter? So here I would like to look at trace minerals and how those levels might affect the immune system and disease severity. So some of the 3 most common trace minerals that have been examined for viral infection are zinc, copper, and selenium. I know with COVID-19, you have probably heard people day after day talk about zinc supplementation, but you don't really hear about the other 2 as often. And I would really like to look at one. I would like to focus in on one based on the CMV alone, and based on the lymphocyte count alone, one of these is superior. And since lymphocyte count directly correlates with mortality, we want to make sure that the body has every means possible to making lymphocytes in order to fight this infection off. And I would like to take a look at copper over the other two. And this study, they actually did look at copper and selenium. But as I dug through some other studies, I do believe that the copper levels seem to be more correlated here. So in this study, they looked at the relationship of serum copper status to survival in COVID-19. And I would highly urge you, if you are in the medical field or if you have any interest in this, to go and look at some of these studies. This one is very compelling because they were able to show that copper levels were directly related to COVID-19 severity. So in this study, they showed that alterations in serum biomarkers of copper and selenium status in COVID-19 are not compatible with just a simple acute phase response, but that serum copper and selenium levels contribute to a good prediction of survival. Let me say that again, a good prediction of survival. So the combined analysis of serum copper and selenium status provides prognostic information on survival odds. Adjuvant supplementation in patients with diagnostically proven deficits in copper or selenium may positively influence disease course. Now, how important is this to know that, you can look at a couple of trace mineral statuses potentially and know whether or not that their disease is going to progress to severity or not. So copper and lymphocytes. This study, which looked at copper and zinc supplementation, they found that recent quantitative and qualitative studies in animals suggest that copper deficiency causes immunological impairment and a decrease in leukocytes. And leukocytes is just the general name for all white blood cells. Lymphocytes are a particular type of white blood cell. In their results of this study, they found that copper depletion had a deleterious effect on the immune system with a decrease in circulating lymphocyte numbers. Monocytes seem to be more resistant to copper deficiency than neutrophils and play a significant role in lymphocyte activation. So copper is extremely important in lymphocyte production, activation, and zinc was not shown to have this correlation. Now, I'm not saying that zinc is not important in the immune system. It is very important, but maybe we are, overlooking things with copper. And there is one problem with zinc supplementation is that zinc supplementation in high amounts can actually block copper absorption. So if you take someone that's already deficient or has a low level of copper and you give them lots of zinc, it will actually hinder absorption. You can look that up. Usually functional med doctors, anytime that you are going to supplement zinc, they will warn that person, do not over supplement zinc. Levels somewhere between 30 to 50 milligrams a day of zinc have been shown to decrease copper levels. And that's also true for vitamin C. Vitamin C and zinc can block copper absorption. So if you take large amounts of those, you need to be aware that you could be pushing your copper levels down. Just to briefly look at some signs of copper deficiency, just so you know that any of these patients that are coming into the hospital with COVID-19 who might already have copper deficiency and be more at risk for having severe complications, because if they don't have enough copper, it's going to affect their lymphocyte count. Someone that has anemia. There are different types of anemia, iron deficiency anemia. Copper deficiency can actually cause iron deficiency anemia, and it can cause it in two different ways. It can cause it because copper is needed for iron absorption, so you can actually have low levels of iron in your body due to copper, or it can cause a dysregulation of iron. So iron will start to build up in either the liver or in the tissues, and it will look like someone has iron deficiency when really they have a copper deficiency. So there are some studies out there, and I saw some news articles linking iron deficiency anemia to higher risk of developing severe COVID. So it would be important to determine, do these patients actually have iron deficiency, or do they have iron deficiency brought on by a copper deficiency? So some other signs of copper deficiency just in general are low body temperature, bone fractures and osteoporosis, because copper is essential in collagen production. Also low white blood cell count, just like we said. Irregular heartbeat, loss of pigment from skin. Copper is needed for melanin production. Also premature gray hair, that could be lack of melanin, or it could be also lack of something called superoxide dismutase. And zinc along with copper helps to make this enzyme called superoxide dismutase. And without that, you can have free radicals in your body. You may develop premature gray hair. Also thyroid problems, frequent sickness, bruising, that can be another big sign of copper deficiency. Joint pain and inflammation. That's always hard to determine since it's such a general symptom that many people can have. But then also histamine intolerance, and we're going to talk about that later. Copper, along with a couple other vitamins, are needed in order to make enzymes that break down histamine in the body. So very key to have copper for histamine degradation. So if we look here at the chart from this study that they did on copper and survival rate in COVID-19, as you can see, the death rate, which is the first column there in red, and the copper levels. So the copper levels were correlated with death. And the patients who were discharged, as you can see in the blue, they had higher levels of copper. And then you have the control there. So with death and discharge, copper levels were correlated with copper. COVID-19 severity and death were correlated with copper levels. So let's take a look at something else that they frequently give patients with COVID in the hospital. And it's not something that the patients would receive immediately. So I feel like, and let me try to explain, steroids are not something that are initiated at the beginning of an infection. And that is because steroids can suppress the immune system. But once they feel like the bacteria or the virus, the body has started to be able to get that under control, then they may give steroids depending on what's going on in the body, because the body, it may be going through a state of sepsis where the immune system is just hyperreactive, and you don't want the person to die because of the hyperactive immune response, and you're trying to calm down the inflammation. So it becomes hard because you don't want to give steroids in the beginning of an infection if the body is able to fight off the infection and deal with the aftermath of the infection, because steroids will actually suppress the immune system. It becomes crucial in these patients that are admitted to the hospital with COVID-19 to say, does this patient have reactivated CMV? Because unfortunately, CMV is going to replicate big time with steroids. And in this particular clinical trial or clinical study, they found that dexamethasone enhanced the production of human cytomegalovirus by 34-fold over that in untreated cultures. So dexamethasone is an extremely potent steroid. And when they look at this particular steroid along with other steroids and how they can impact cytomegalovirus replication, dexamethasone is going to be the biggest one. And unfortunately, like I said, the lungs have so much inflammation going on that the doctors feel that they have to do something to get the inflammation down, because that's what patients are dying from. They're dying from the inflammation from the immune response. But what if what's going on here is that the patients are, maybe they're fighting off the COVID, but what's happening is maybe they're in that kind of that transition time where we are starting the the steroids, and then it is causing further CMV replication. So it's definitely something to consider here. Are there different choices that we could be making with these steroids? Maybe we could be doing inhalation steroids. Still, there's a chance of that causing CMV reactivation, but at least, we're limiting it to the lungs where we are worried most about the inflammation, since COVID does seem to cause very severe COVID-related pneumonia. So let's take a look at a couple images showing what COVID-19 lungs and CMV reactivation in lungs looks like. It becomes very hard to really tell in something like this. With COVID-19 lungs, they have been described as much more severe and much more incidence of fibrosis and damage occurring than in your typical pneumonia. And if you look at the x-rays of patients with CMV reactivation in the lungs, you're going to see that same sort of pattern that you're seeing in the COVID-19 lungs. So just another indicator that, maybe this is what's causing the lung damage. Maybe it's not the COVID-19 virus itself in damage. It could be a combination of both, of course, but definitely a warning sign that this pneumonia that COVID is causing looks a lot different than your typical pneumonia, much more severe, and it does mimic the images that we see here in a CMV reactivation type situation. So just to look at the whole process of, what happens during a CMV reactivation when someone is sick or immunocompromised. CMV reactivation is associated with a dramatic increase in lung fibrosis. Impaired immune defenses encourage CMV replication. So if the body is dealing with another virus or infection, bacterial, immune defense is going to be down, and it's going to cause that latent virus to be able to start to replicate. CMV might also alter immune defenses against infections, favoring the occurrence of nosocomial infections in critically ill patients, and enhance compartmentalized pro-inflammatory responses, further exacerbating lung inflammation. So in this figure here, you see that you've got a situation of, in this case, bacterial sepsis. Of course, in COVID, we're looking at more of a viral sepsis, and that's triggering the whole immune response, cytokines, TNF alpha, IL-6, some of the other inflammatory cytokines, which is causing CMV reactivation, and then that in itself is impairing the immune system, your lymphocytes, natural killer cells, T cells, and that is just further contributing to the bacterial sepsis in this picture, or in our case, maybe viral sepsis. And as you can see, you're also getting direct lung inflammation, direct lung injury, inflammation, and fibrosis. One key factor here that I believe that we really need to concentrate on, especially in the lungs and other organs as well, but is the possibility that the patients are really suffering from basically an inability to deal with mast cell activation. Mast cells play a huge role in infection. It allows the body to locate where the infection is so that it can be better able to fight the infection. Unfortunately, in some cases, because the mast cells cause such a release of inflammatory cytokines and factors, it can also be very difficult for a body that maybe does not have the resources and able to kind of go in as a cleanup crew to get rid of this inflammation that the mast cells are causing. So what is a mast cell? A mast cell is a type of white blood cell that is found in connective tissues all throughout the body, especially under the skin, near blood vessels and lymph vessels, in nerves, and in the lungs, and in the intestines. They play an important role in how immune system responds to certain bacteria and parasites, and they help control other types of immune responses. They contain chemicals such as histamine, heparin, cytokines, and growth factors, and they release these chemicals during an allergic reaction and certain immune responses. And they can have many effects, including widening blood vessels and angiogenesis. During an allergic response, they can cause flushing and itching. And in large amounts, they can also cause abdominal cramps, muscle pain, nausea, vomiting, diarrhea, low blood pressure, and shock. Mast cells are a part of the body's immune system and a very important part. But this activation that they are causing, like I said, in some people, they may not be able to deal with, like I said, they don't have the cleanup crew to go in and break down the histamine and deal with the inflammation that's happening as a result. So the body basically is going through a hyperinflammatory state to try to get rid of this virus, whether it be COVID-19 in the lungs, whether it be CMV reactivation in the lungs. The body is simply not able to calm this inflammation once it occurs. So let's look at CMV and mast cell activation. So the lungs are a noted site of acute, latent, and reactivated CMV. Interstitial pneumonia is the most dreaded manifestation of CMV. So it's a known problem in CMV, this horrible pneumonia that it can cause. In this particular study that I've noted at the bottom, they found that host infection mast cells become rapidly activated and promote the recruitment of protective CD8 cells to the lungs. And also, there's just a peak viral load and a faster clearance of productive infection when this happens. So these results reveal a novel crosstalk axis between innate and adaptive immune defense against CMV and identify mast cells as a very big player in the immune system, especially when it comes to CMV. Now, like I said, mast cells release a lot of different chemicals. And one of the chemicals that I have really focused on in this whole hyperactive immune response is the fact that mast cells are releasing histamine. And if we look at all the symptoms of elevated histamine, it definitely is alarming because these are just so many of the symptoms that our COVID patients are suffering from, and it is basically from a mast cell response. The runny nose, the bronchoconstriction, tachycardia, blood clots, gastric acid secretion, swelling or inflammation. I know when I had COVID, my rings did not fit. I definitely had some GI issues, tiny bit of tachycardia. I did not get hit as hard for a number of reasons probably, but my family members definitely went through a lot of these symptoms. So not all of them are on this list for what can happen in your body with elevated histamine, but these are definitely some of the most common. And the most worrisome of these effects are going to be the effects that the elevated histamine has on the lungs. As far as when histamine is elevated, it becomes very difficult to breathe. It can cause bronchoconstriction. And also, in my daughter, like she had to be placed on a diuretic, showing that the capillaries were becoming more permeable. So basically, if you can see there in that middle picture, fluid starts to accumulate in the tissues when there's high levels of histamine. Also, there's higher chance of having blood clots. And then histamine in the heart can actually cause more of a dilation, and therefore the heart may end up working just harder and faster to pump the blood when there is elevated histamine. Because it's causing the blood vessels to dilate. And so when the blood vessels dilate, the body wants to keep the pressure the same. So it will do whatever it can to try to keep that pressure up. And that sometimes may require the heart to just beat harder and faster. So why are some people having an issue with this mast cell histamine response that's going on that maybe some people are not having the same issue with? Well, One of them can be the fact that their body just does not have the enzymes that are needed to break down the histamine. So their body may be able to, strike up that immune response, and help the body to figure out where the virus is so it can kill it and then go in and mop up the histamine. But for some people, they just don't have enough of this enzyme. And this key enzyme in histamine degradation is called DAO, or diamine oxidase. And if you're not making enough of this enzyme, you can have an impaired histamine degradation. And like it says here, you may have a number of symptoms developing because you don't have enough DAO. So DAO requires copper, which we've talked about before, and I did mention that you could have histamine degradation issues with not enough copper. Vitamin C is another one, and then vitamin B6. All three of those are big cofactors for DAO to work properly. So I did not go into it in this presentation, but vitamin C is going to be a big player in histamine degradation. And there are some studies out there showing that when they check vitamin C levels in patients with severe COVID, their vitamin C was either at just almost zero or completely undetectable in the bloodstream. So vitamin C can be a huge help when one is trying to, go in and get rid of this histamine that is happening as a result of the degranulation of the mast cells. But also, again, like I said, copper is very important for lymphocyte production, but also equally important for this enzyme DAO to work. So there's two good reasons to make sure that copper levels are optimal. And unfortunately, serum copper is not always a great marker. Because when there is inflammation in the bloodstream, the body will have higher copper levels, but it's pulling it out from the tissue. So it may give you a false sense of the patient having enough copper, but when really they don't, they are just using every bit of copper that they have to try to fight off the infection. So there are some studies out there looking at mast cells, histamine, and COVID-19 as a very important indicator of disease severity. So severe lung injury in SARS-CoV-2 patients is considered the result of immune hyperactivation that involves both innate and adaptive immune responses. And definitely the mast cells and the histamine release is going to be something important to look at here. If you look in the news, there's not a whole lot about CMV related to COVID-19 yet, but I have found in other countries there are reports of CMV in COVID patients within just the last couple of months, that this has been something that they have found in New Delhi patients. So maybe this is something that is on the horizon for them to look at as far as, keeping this in consideration along with COVID, that maybe this reactivation is occurring. Now, the typical CMV treatments we see are ones that are typically used for patients that may be having organ transplants, also could be used in patients with HIV. And I'm not going to go over everything here, but these are going to be the most typical drugs that are used. The most common first-line antiviral that's used in the hospital is ganciclovir. But this is a very toxic drug, and there can be issues with a renal impairment. So with these patients that are already in the hospital with COVID, potential CMV, and I don't know how long that they've been, progressing in disease, there can be issues with already some kidney impairment. So giving a drug like this, it may be a good idea, it may not be. That's something that they're going to have to look further into. But checking CMV levels and then deciding, how they're going to proceed is at least a good step to at least be looking for this virus and checking for it instead of just overlooking it. So what are some of the alternative treatments for CMV if we are not doing your typical antivirals that treat CMV due to some other extenuating factors, worry about toxicity and that sort of thing? There are a couple other pharmacological interventions that we could make based on the patient's previous medical history. And then there are some other things that we could do non-pharmacological in order to support the patient. I'm going to talk about a couple drugs here just because they definitely hold some interest as far as decreasing COVID severity, and they are also shown to inhibit CMV. So the first one of these is metformin, and there's been a few studies showing that metformin has a benefit in COVID-19 patients, and they may patients who are on metformin may have a lower incidence of disease severity. Metformin has also been shown to be a strong inhibitor of CMV replication. So metformin treatment could be used as preventative for chronic low-grade inflammation associated with CMV. And another study here looked at it, showing that it was a potential repurposing drug that they could use as a safe and effective treatment for CMV. Another drug to look at, especially because a lot of these patients with COVID-19 have hypertension issues, are the calcium channel blockers. If they are on an alternative treatment for blood pressure, it may be a good idea to switch them over to calcium channel blockers, for the main reason that calcium channel blockers have been shown to decrease mortality in patients with COVID-19, as you can see over here in this study. But calcium channel blockers, maybe they are working because they actually do inhibit viral replication by blocking calcium entry into the cells. So many viruses, including SARS-CoV-2, require intracellular calcium for replication. And calcium channel blockers have been shown to decrease mortality in these patients with COVID-19, and they are being currently explored as an alternative treatment for CMV, because for some patients, they just simply cannot be on these toxic antivirals every day, and it's not a solution for them long term. So what treatments do we have here if we have a patient that has COVID-19 and they've also tested positive for CMV? Well, you have your antivirals that I mentioned, as well as the risks of using those. But maybe we should focus on supporting the body through this immune process and help the body in order to, fight off this infection. And that may be one approach that we could use. So I would recommend high-dose vitamin C. I'd recommend initiating that as soon as possible, especially if anyone starts to exhibit any type of respiratory symptoms, shortness of breath, tachycardia, problems breathing, along with these other symptoms that I mentioned earlier showing high levels of histamine, the tachycardia, swelling. They may have issues with temperature regulation. Those are some things to look out for. Another thing that you would want to make sure that you administer that I really did not touch on in this presentation is thiamine. Thiamine is vitamin B1, and it is very important in the body to fight infection because it is involved in the first step of making energy. It is required in order for the body to make ATP. It is a water-soluble vitamin, so the body does not store a lot of this in the tissues. And with COVID, I also did not touch on this in this presentation because I really wanted to concentrate on CMV, but COVID has been shown to create a very high metabolic state. So a hypermetabolic state is going on here. And they looked at resting energy expenditure and how far above resting energy expenditure a lot of patients were displaying. And when they check those, they're counting kilocalories that the patient might need. And typically they might think they need, like, let's say for one patient, 1,800 calories. And in a patient with sepsis, they might need 30% above that. Well, in some of these patients with COVID, their resting energy expenditure was going in the upper 200%, almost to 300% of resting. So their energy requirements are extremely high during this state. And they're requiring more calories, they're requiring more energy. And thiamine is a very safe water-soluble vitamin, definitely needed in the first part of the body's process of producing ATP. So it's extremely crucial for that. They've shown that some patients with COVID-19 severe cases have developed even Wernicke's encephalopathy, and that is a case of severe vitamin B1 deficiency to the brain. So the fact that Wernicke's encephalopathy is developing in some COVID-19 patients shows that thiamine is crucial for these patients, and it's something not to be overlooked. They have one study out showing that thiamine decreased the rate of blood clots by 81%. And a lot of these patients are having blood clots, and it can be from the high levels of histamine. It can be from a lack of thiamine, which it plays several roles that it could prevent that. Thiamine is also need to make acetyl-CoA, which in combination with choline in the body can make acetylcholine, which is a very important neurotransmitter. So very crucial during this. So the next thing you want to also do is make sure you're managing that mineral status and the vitamin status. So things like copper, in addition to the vitamin C, which I left by itself because it is so crucial with these patients with the high levels of histamine due to the mast cell degranulation. Copper, most importantly, selenium and zinc, important, but definitely we want to focus on the copper, because if we do not, we're not going to be able to make the lymphocytes that we need for fighting the virus or viruses. Also looking at vitamin status. So like I said, copper, vitamin C, vitamin B6, those three things are needed to make DAO to break down the histamine. Also managing the nutritional status, like I stated earlier, hypermetabolic state. We want to make sure that we're giving the patient enough calories. They're getting enough nutrition, supportive through this. I know when my husband came home from the hospital, he was eating, and he said he was eating a decent amount at the hospital, but he still dropped 10 pounds because his body was just burning through those calories. Another thing I really didn't talk too much about here, but with the high levels of histamine, your body needs DAO to break it down, but an additional way that you can help the body immediately to break that down is to give something called a methyl donor. And there are a few different methyl donors. Choline's a methyl donor. Methylcobalamin, which is the active form of vitamin B12, it is a methyl donor. And the body can take those methyl groups off of these methyl donors and basically deactivate the histamine. So methyl B12 is a really good methyl donor that would be something that would be available to use in the hospital. And there was actually a study showing that methyl B12 actually aided in lowering mortality in COVID. And then also another thing to consider, like I stated earlier with the steroids, if a patient has developed CMV, we really want to rethink giving systemic steroids and maybe limit that to inhalation form steroid, or at least we need to look at dosage, maybe a different form, maybe a less potent form that is less likely to cause CMV to replicate. We do need to get the inflammation down, but I do believe that we need to look at some of these other things first, like the high-dose vitamin C and the thiamine, managing mineral status and nutritional status and giving methyl donors. And then if that is not working, then move to the steroids. But right now, if we know the patient has CMV and we are giving them steroids, it's such a danger there of just causing that virus to get even stronger, and we do not want that. So just to kind of summarize here, so the risk factors for CMV disease and its recurrence include corticosteroid use, prolonged mechanical ventilation, and lymphopenia or low lymphocytes. COVID-19 contains these aspects due to its disease characteristics. Moreover, these are risk factors for disease recurrence or secondary infections in patients with COVID-19. CMV infection may be associated with accelerated immunosenescence, leading to the attrition of the naive T cells. decreased naive T cell response may contribute to subsequent uncontrolled cytokine production and worse clinical outcomes. So physicians should be extremely aware of CMV infection in patients with COVID-19 acute respiratory distress syndrome compared to that with the non-COVID-19 ARDS. Let's look at how this disease could potentially be progressing in some of the patients, not all, but definitely some of them. So you start out with your infection of SARS-CoV-2, you move to an immune system overwhelm. CMV is reactivated. You get mast cell activation. You get decreased histamine degradation, resulting in CMV lung injury. And then here we have the steroids, potential increased CMV replication. And then we have ventilation, potential increased CMV replication, followed by death. I think a lot of these things could potentially be avoided if we would look a little bit closer at these patients, especially with the strong risk factors for developing CMV, with the history and with the literature that we already have available to us concerning CMV and these disease states that are the disease states that we know that patients with COVID-19 have the highest risk for developing severe mortality. So I hope this has been helpful, and I hope that we will see more research in this area, and I hope that we will see some of these treatments that I've mentioned to be used more frequently in the hospital, especially high-dose vitamin C early on, especially thiamine given early on. There are ongoing clinical trials right now with initial results of these trials showing that giving high-dose vitamin C and thiamine early in therapy, actually just vitamin C alone, if given early enough, has been able to get patients off mechanical ventilation within 24 to 36 hours in one study that is nearing publication. I'm very excited to see that published, and I'm hoping to get that information out to you as well when it is available. Thank you.